I'm sure you've all seen that side posture position. You kind of do that to the person. If there's a situation where you don't want to do that because they're too old, perhaps, they might be too acute, this is an alternate. This is a soft tissue technique where you're going to grab or pinch the skin in the lumbosacral region. This is very similar to skin rolling. Now, some people like skin rolling. Some people don't like skin rolling. And some people, just because of the nature of how their tension and the tissues are, you can't really even pinch or pick up their skin. Well, so what I like to do is bend my index fingers like this, and use my thumbs on my index fingers as opposed to using the tips like that. It gives me more strength. So, as you can see here, I'm just kind of pinching up. See how I have my index finger and my thumb? So, I'm going to take slack up, and then just pull straight. Slack up.
Holy.
Slack up.
Oh, holy.
So, and Lilia was saying in Mexico, her grandmother would do this for constipated babies, and then it kind of...
They just start pooping all over the
Right
place.
there. So, by doing this, this is obviously indirect. I'm not really doing anything to the joint directly, but by lifting up the tissues, and the releases that you're hearing aren't really osseous releases, this is soft tissue stuff. Yeah, it's fascia release. But it's still, you know, one thing connects to another thing, connects to another thing, right? So by doing that, it's connecting and affecting the facet. So it can produce a relief or a release, you know, of a problem. So again, if you feel like you don't want to do a side posture issue or setup, again, it could be an age-related thing. You can do this as an alternate. Sometimes I do this, you know, in conjunction with other things, just to kind of add one more thing, you know, in this kitchen sink context of, you know, loosening things up. Okay?
You didn't get down into the SI joint, really, did you?
No, this is more like lumbosacral.
And how far up do you go?
You know, it kind of in the lumbosacral region, you know, it doesn't really work so well. Even though I can pinch Heath up here, it doesn't work like that for you know, quite a few people. So it's primarily in the lumbosacral region. Is how it, when you read the notes, that's what it's designed for. You know, it certainly could be used if you get, you know, the ability to kind of pinch somebody's skin and go up higher if you chose to. Okay. So another thing I want to demonstrate. You guys all know the Hibbs test, right?
Mm-hmm.
Yes. Yes.
Mm-hmm.
All right, so if I put my finger on the SI, you think I might be feeling some motion there? And if I do the Baratovich test, think I might be feeling some motion there? This gives me more quality of motion than the other one does because of the internal rotation aspect. But this is another way to evaluate sacroiliac mobility. This is not as direct because it's using the femur and the lower extremity kind of as your lever, but it can also give you information. So when you're doing the orthopedic tests, in addition to like, is this causing any pain? When you're doing this for a patient, your hand is here. It's like, yeah, I feel movement. That's okay. That gives you information, right? So the more information that you have, the better. And like that. Okay, so the basic lumbosacral position. So this is what we're going to be introducing and starting to do with next week. If you want to, and when we finish with the demonstration, you can do the vertical skin traction and you can do some setups. I probably will go ahead and manipulate Heath's back just so you can see what it looks like to do it. But I don't really advocate you doing that today. Next week, that's what we're going to, well, not next week, the week after, because next week there'll be no class. So the choreography, quite often, that, you know, I kind of run through, either for a specific problem or sometimes just in general. I'm going to check the leg length. He has a right short. I can check his Achilles tendon. Is that sensitive in there? How does it feel over here? All right. I don't usually feel the legs, but sometimes you can feel them if you get that quality or sense of tension. You know, just, you know, even though my focus is really down here, you know, I tend to kind of, you know, go through, so I just get kind of the feeling of the entire spine. Find the PSISs, look for my static stuff, create a crest trochanter, go into joint play, go back and forth several times, kind of just illuminate any kind of artifact. And sometimes I change the rhythm a little bit of how I do the pressure, just to kind of switch it up so the patient isn't necessarily expecting, you know, the rhythm of it. And this side is tight, so it seems like he's got a right SI fixation. If I was to palpate lumbar spine, I know this from Monday, he's got tight lumbar stuff on the left. So quite often you're going to see compensatory patterns back and forth. So the basic position, I'm going to have the patient turn on their side. This is why it's called side lying or side posture. And then you notice that Dr. Heath brought the headpiece up. That's to more or less keep his spine straight. Because if the headpiece wasn't there, and because of his shoulder, he'd be more like that, right? So you want to kind of get that. So then I'm going to have him scoot a little bit closer to the edge of the table. I'm going to have him bring his top leg up, bottom leg is straight. Doesn't necessarily need to be quote-unquote straight like an arrow, but it needs to be straight. I'm going to take his arm, grab his elbow and his wrist, kind of pull him around so that I'm kind of creating a rotation of his torso, because a lot of this rotation is important for the manipulation. Now, some people, when they do lumbosacral manipulation, they stack the shoulders. Stacking the shoulders means that he would be more like this. Now, that's kind of personal preference. I prefer this. This hand is on the shoulder ball. This hand is on the lower rib cage. Sometimes people will put their hands like that so that my hand is on his shoulder ball. My experience is if my palm is in that shoulder ball and I need to use a fair amount of pressure to keep him down like that, sometimes that's uncomfortable. But if his hand is there and I'm on top of his hand, it's more comfortable for him and I can use a little bit more pressure. So what I want us to kind of experiment with today this is another way to evaluate sacroiliac mobility. So I'm using his femur and the tibia fibular complex kind of as a lever. It's between my legs. And I'm going to use my fingers, typically index and middle, on his PSIS. And what I'm going to do is move his femur between my legs. And then what I'm feeling for is like, I can feel that PSIS move. And then when I get that sense that that's where it seems to move the most, this is the angle that the femur needs to be at for the correction when I do my thrust. Because when I make my thrust, which is a body drop, there's also a kick, which we'll describe more next class. The body drop produces force and impulse. And that impulse has to go somewhere, right? That impulse is going to follow along the femur. And so if I'm putting him in a position that where I feel the most movement, that's where the force is going to go. So that's why I know the force is going to go to the SI joint and not somewhere else. Okay? So once I've made that determination, I'm like, yeah, that's the position. And then again, scoot it close to the edge. Because when I make this correction, and you'll see, his leg is going to go down like this, right? If he is too close to the table, I'm just going to jam his thigh into the edge of the table, and it doesn't feel very good. All right, so there we go. I feel the movement right there. We're going to talk more about this next week, but just so you can see what it looks like, I'm going to use my pisiform on his PSIS. Slack is out. Nice deep breath in, blow it on out. This is called the rock, lock, and then drop. Now turn on your other side. So again, this is the same basic position. Scoot a little bit closer to this edge. Grab his arm out, lower rib cage, shoulder ball, bottom leg straight, top leg up. And now I'm going to be feeling, again, for the sacroiliac joint. But in this case, I'm really going to be manipulating his lumbar spine. So one of the things to be aware of, and we're going to talk more about this when we do lumbar stuff, when his leg, if you imagine his line of his body here, his knee is at 90 degrees, right? So if I bring his knee closer to his head, this is starting to make motion or movement in his lumbar spine. If I'm down here, this movement is more in the SI joint. And so if this is, I guess you could have this be 0, and this could be 180, and this could be 0, and this could be 180. But in any case, typically 90 degrees or greater, because this would be the 180 degrees, this is mobilizing lumbar spine. 90 degrees and less, this is starting to get me information about SI joints. So we'll talk more specifically about this when we get to that particular aspect. But because I felt tension in the lumbar spine, so I can find his crest, I can go down, that's going to be what vertebra? L4. So movement right there. I can feel that. Put my finger up one, this is L3, movement there. Come up one more, L2, movement there. So I can localize which vertebra I'm going to manipulate, rather than shotgun in official barrels. Just that kind of what they call pop and pray. The chiropractic profession calls that the $1 million roll. Because you can certainly put someone in a position like this and whomp on them, and something's going to happen. But it isn't necessarily the right thing. So I'm going to pretty much go for L4 because that's that area that it's not in the center of the lower back, but it's in the center of the lower part of the lower back. In this case, I'm going to use my index finger as a contact as opposed to my pisiform, which I use for the SI. It's the same kind of thing. Just the correct info on that. You already released. There you go. So, boom. So that's what it looks like. As we mentioned in class, you don't want to mess with the the anatomical barrier. Now, high velocity, low amplitude means like boom, right? Because of this long lever, it looks like a lot of stuff's happening, but really not much is really happening. It's just being localized to the that particular vertebra that I'm trying to address. So this is where the skill comes in to make sure that you can do that and do it at the right place. So you can go ahead and practice a vertical skin traction, get somebody in the setting them up in the side posture.